right, good afternoon. We may have a few other people trickling in and joining us, but I'd like to welcome you to our panel on Rethinking Mental Health Care in Texas. My name is Kate Murphy. I'm going to be the moderator today, and I am the Mental Health Policy Fellow at TPPF. This is some relatively new territory for the Texas Public Policy Foundation, and we are excited to be engaging in the conversation surrounding mental health care issues in Texas. Since I've started working at TPPF, I think one of the most profound statements that I've heard related to mental health was from Pat Deegan. She said, "Help isn't help if it is not helpful," which is pretty simple, but very true. Help isn't help if it's not helpful. And that's what we're going to be talking about here today, are the types of help that would be helpful. We're going to be talking about practices, systems, and actions. In terms of practices, there was a cartoon that Scott Chambers drew back in 2000 called Tested and Proven Methods of Drowning in Help. And in this cartoon, there's a man who is drowning in the ocean, crying out, "Help!" And he looks up and he sees a wheelchair fall down from the sky. And it hits him on the head and then sinks to the bottom of the ocean along with him. I think this really reflects some of the approaches we've had to practices related to mental health care in Texas. A lot of the practices that we're seeing are not necessarily helpful. So our panelists today are going to discuss some of the best practices, practices that are actually going to serve people with mental illness in Texas. In the second cartoon in Scott Chambers' series, we see another man drowning in the ocean, crying out, "Help! Help!" And all of a sudden he looks up and he sees money raining down. And he looks very happy because, you know, money, it fixes everything, right? But then the money hits the water and floats on top while the man continues to drown. And I think this gets at some of the systemic problems we have with mental health care in Texas. And we're going to be talking about some of the systematic changes that Texas needs besides just throwing more money. Money is not the end-all, be-all of mental health care in Texas. It is not the only thing that needs changing. The systems are troubled, and I think we've seen with the Sunset Commission's review of the Health and Human Services Commission and the Department of State Health Services just exactly what some of the unhelpful help that we have in Texas is and the things that need to be changed. Finally, we're going to talk about actions, which brings me to Scott Chambers' third cartoon. You see the man again drowning, calling out for help, and a big book entitled Report on Drowning falls from the sky and floats on the water while he continues to drown. And this is one that resonates pretty strongly with people like myself at a think tank. We write a lot of reports, but at TPPF, we like to think of ourselves as a do tank, not just a think tank. So we're going to be discussing some of the actions that we can take to move Texas into the future of mental health care that we want to see, that would make Texas really a model for the rest of the country. And joining me today, I have my illustrious panelists. We have Leon Evans, who is the vice president, or not the vice president, he is the president and CEO of the Center for Healthcare Services in San Antonio. Leon has been working in Texas to improve mental health care for the past 38 years and has truly developed an innovative and integrated system of care that has served as a model nationwide. Also, we're going to hear from Colleen Horton, who has been working for 20 years on disabilities issues in Texas and has been with the Hogg Foundation for the last 5 years as their program policy officer. Finally, we're going to hear from Dr. Andy Keller, who has over 20 years of experience in behavioral health care policy. He's with the Meadows Mental Health Policy Institute and has particular expertise in health and human services integration, behavioral funding, managed care organizations, and best practices. And I'm so excited to hear what our panelists have to say, and we're going to get kicked off hearing about different practices, systems, and actions with Leon Evans, and he's going to tell us about some ways that we can provide helpful help here in the state of Texas.
So, can you hear me? Yeah, thank you, Kate. I want to talk a little bit about the problem. Most of you already probably know this. 25% of everybody on this earth has a diagnosable mental illness. It's just that most of us never get diagnosed, right? So we're drinking a little bit. We may be using prescription drugs. We have family problems. We have kid problems. We have problems at work. And, people with severe mental illness in Texas die 29 years sooner than the general population because, they're self-medicating. They never get to primary care. They're smoking. A lot of them are also using illegal substances. But when they do die, they're $1 million patients because they're dying of congestive heart failure and liver disease. And guess who pays for that? I mean, we wonder why the cost of health care is just plummeting in the United States. In fact, Malcolm Gladwell, the guy that wrote The Tipping Point, wrote an article for the New Yorker where he describes this phenomenon. He calls it $1 Million Murray. The chronically and persistently homeless. You think those people that are homeless don't cost us any money as taxpayers? Google cost of taxpayers to the homeless. You get all kinds of reports. I did it 3 or 4 years ago. The cheapest report I saw was about $30,000 a year to taxpayers. They have lots of contact with law enforcement. They're in and out of jail. They're in and out of emergency rooms. And they cycle over and over and over again. Child Protective Services, is that a big problem here in Texas? Who's abusing and neglecting their children? Now, I'm going to say generality. Not all families are like this, but most of those families are abused children themselves. Okay, so we take their children away. We put them in foster care. We give them no trauma-informed care, so they've been broken. Then when they get to be 18 or 19 or whatever, we cut them loose, right? They age out of foster care. Well, I have 2 sons who are both very successful. If I would have cut them loose when they were that age, they probably wouldn't have done too well. One's a doctor today and one's an international business person. So these kids go to the street. They have lots of problems. Our jails, I'll guarantee 25 to 30% of people in jail have diagnosable mental illnesses. Most go untreated. And so can you see how the problem here is really harming the public safety net and costing taxpayers dollars? And we have lost lives, lost relationships, and the World Health Organization and the National Institute of Health have done studies on what they call disease burden. And 3 of those top diseases that cost society the most money in lost productivity and actual health care cost are mental illnesses. If you want to add substance abuse in there, well, no telling what percent it is. So what we've done in Bexar County, and by the way, our funding is very poor per capita wise, and I'll talk a little bit about this last time. We actually got punished because we refused to have a waiting list. And I'll talk some more about that. But what we've done, and Kate was kind enough to mention, we have lots of national recognition. We got the American Psychiatric Association a Gold Award. We had the southern states of the United States come and visit recently. We've had 6 or 7 countries, and almost every state has come to visit. In fact, I was in Baton Rouge last week because they want to implement our model. And just this past year, Wyandotte County and Johnson County, Kansas, developed a program similar to our Restoration Center, and the same thing's true in Polk County, Des Moines, Iowa. So we have, and when they come, they see the programs we've been able to knit together, and there's lots of local investment, by the way. This is not all state dollars. And there's just not enough dollars at the federal, state, and local level to handle this problem. So one of the things people are always excited about when they visit us is we found a way to blend, braid, or integrate those local, state, and federal dollars and try to drive out the waste and duplication. And sometimes we funders all want us to meet their reports. Every funder has a different set of outcomes once they account for their money in a different way, and so sometimes we kind of violate some of those trusts because it's just stupid, and we do a lot of things at the public level and policy level and funding level that don't drive outcomes. We value units of service, we value volume, but do we really value outcomes? That triple aim. In fact, when we budgeted this last go-around, I told the people that I work with, money is power. So don't bring me a budget that doesn't show 3 things. I want you to show me how these dollars are going to improve the patient experience, how people are going to get better outcomes, and how we can drive down cost. I want to know how we can be more efficient in the way we do business. Steve Forbes mentioned this. If the only tool you got's a hammer, everything looks like a nail. We don't need everybody to see a doctor or a psychologist or a psychiatrist. In fact, some of our most important programs, we use peers. We use people in recovery. And I can kind of go on, but I'll give you a quick example. So we have a PATH program. So we have professionals who go out under the bridges and in encampments to the homeless, and we try to endear ourselves to people who are mentally ill and get them in and get them into treatment. Well, we have a fairly high no-show rate, even though we connect with people. And so we hired a peer, a guy who used to be homeless and addicted and mentally ill, who's doing really well. And he said, let me go out. Well, he's able to talk to those folks because he used to be mentally ill and homeless and addicted himself. And like he said, I was in the same shipwreck as you, except I got off. Don't you want to come and let me help you get off? And so our no-show rate just plummeted, and so we use, well, they don't cost a lot, but, they really affect people's life. There's a lot of motivational engagement, and there's ways that we can drive better behavior, better outcomes that don't cost a lot of money. How much time do I have? Am I okay? Okay, because I can talk forever. So when people come to visit, we've got all these programs, and things they always say is, how'd you get everybody to work together? So we have these community collaboratives. We have one for adults. It's called the Medical Directors Roundtable, and we have one for children. And the one for adults is actually chaired by an emergency room physician. And hospitals' emergency rooms are just packed with the mentally ill. They get bedded. In fact, San Diego Scripps Center did a study on the high utilizers in San Diego several years ago. The Scripps Center is a famous research center in San Diego. In fact, they had a Nobel Prize winner out of there a couple years ago. And so they looked at the high utilizers in San Diego that the county was paying for, and the high utilizers were costing the county about $200,000 a year. And most of the cost wasn't in jail and emergency rooms like you would think. These people actually get bedded into the hospitals because the hospital emergency rooms are real small. And once you get in the hospital, they start finding all these horrid diseases, and then they got to treat you, congestive heart failure and liver disease. So what we've done is we brought law enforcement to the table. We've brought consumers and families. We've brought the medical community. We've brought judges, anybody that wants to come. And we're not a bureaucratic entity. I actually give control up of my local and state dollars to have the community help me figure out how to solve these problems. So we collected a lot of data on cost and outcomes. Everybody in the room gets to see it. A lot of people say, that's a problem, that's not going to work, and so we change it. We change our practices, we change what we do, we actually see if it works or not. If it doesn't, we try something else. There are lots of things that are unfunded. Like, when we started our jail diversion program, the biggest problem wasn't mental illness, it's alcohol and drugs, just like in your community. But Texas didn't fund treatment for alcohol and drugs. We bring down enough money to bring down the federal block grant and a little bit, and we just started some Medicaid billing not long ago, but hardly anybody bills for it. So we said, okay, we've got to find a way to do sobering and detox. And, see the senator in the room, we started this homeless program, the Haven for Hope. And it was the vision of Bill Greehey, who was the past president and CEO of Valero, the most generous, kind person I've ever met. And he saw this TV show about the homeless, and he called the mayor up and said, we just can't have people languishing in our community. And the mayor was smart enough to put him in front of the task force. So now we have this Haven for Hope campus, and it's like a $107 million campus. The homeless count in downtown is 70%. Remember, I told you earlier, the chronically and persistently homeless are people with mental illness and substance abuse. So the county judge calls me up and says, Leon, don't we do some things for the homeless? And I say, well, yeah, yes, Judge Wolf, because he knew Mr. Greehey was going to hit him up for some operational money. And so I met with Bill Greehey in his office. He was talking about, the fact he wasn't going to give handouts to people. He wanted to give them a hand up. So to actually go on the Haven for Hope main campus, you have to sign a transformational pledge that says you'll be alcohol and drug-free and that you'll work 8 hours a day. Well, I know some single moms are putting through nursing school and other people going through welding school and stuff, but it's not like most shelters. It's not there so you can get just a place to sleep and a warm meal. Then you get kicked out on the street the next morning because if you and I were homeless, we'd go get a job the next day, right? Well, these people are sick and they're impaired, so they walk right out the door. They start panhandling, drinking and drugging, and we're reinforcing or enabling them to stay sick and ill. Well, that's not great. He doesn't give his money away to feel good. He gives his money away to help people. But there is a part on Prospect Schoolyard for those people who won't sign the transformational pledge, and I actually operate that. And so we do motivational engagement, again, with peers. We've taken psychiatrists and put them in that place. We also have Center for Healthcare, CMS had healthcare innovation grants recently. We got one of those. We're bringing primary care. And when I was visiting with Mr. Greehey, I basically told him his plan wouldn't work because there was no capacity. We were already serving over 2,000 more than what DSHS paid us for adults and mental health, and there's no treatment for alcohol and drugs. And so, I said, your plan won't work because there's no capacity to treat the people that really cost society the most money. And I could tell he was interested, and he helped champion us getting some money from the legislature to renovate what's called the Restoration Center now, and for the biennium and 1 year's treatment. Senator Ogden didn't want the state to have to pay for that ongoing, so the deal is that we'd keep data, and if we could prove up to the local community that this was saving them money, and they would invest, then we could keep it going. And by the way, we've been able to do that. In 2000, the Bexar County Jail was being cited by the Jail Standards Commission for overcrowding and deplorable conditions. They had to buy space from other counties. They brought in I can't do it in 30 seconds. They brought in experts, says you need to build another 1,000 beds on the county jail right away. We started our training law enforcement officers and having an alternative to jail emergency rooms, and we grew by 350,000 people last census. And this year we've had up to 1,000 empty beds in the county jail. And the last I checked was 3 weeks ago. We had 576 empty beds. So both our sheriff, who's a retired 2-star general, she's phenomenal. She had a brother who died of a mental illness. And our police chief require all their officers to go through the 40-hour crisis intervention training, so they get all the role playing. We have 25,000 people a year who are mainly brought to a restoration center who are mainly brought to the restoration center rather than taken to jail or emergency room for treatment. So I got a lot more to tell you, but I have to shut up.
Good afternoon. Like Kate said, I'm with the Hogg Foundation for Mental Health, and the foundation is part of the Division of Diversity and Community Engagement at the University of Texas. It was started in 1940 by the children of former Governor Hogg. So we've been around for 75 years and celebrating our 75th anniversary this year. But our primary goal for all 75 years, even though the name of the organization has changed along the way, was to really advance the mental wellness of Texans. I wanted, before I started answering the question, wanted to make you all aware of a document that you might find helpful during a document, more than a document. During this session, it's our guide to mental health systems and services in Texas. This is our second edition. We prepared one before the 83rd session, and it's really our way of trying to help provide information so that policymakers and advocates and staffers have some resource guide when they're making mental health decisions. So we hope we will be delivering one of these to each legislative office probably next week, and it's also available online. So just wanted to make you all know that that was out there. The question that was posed to us, are we throwing the right lifelines to people living with mental illness? Before I answer the question, I want to point out that lifelines typically implies that we're in crisis. You need something to save your life at that point. But with mental health, we really need to look at a longer, wider continuum of services. We can't just wait until the crisis occurs and throw some lifelines. We need to look at prevention. We need to look at early intervention. We need to look at supporting people who are on the road to recovery, who are really working on their recovery plan and trying to become more re-engaged with their community. But we have the question, so I'll answer it. Are we throwing the right lifelines? Yes, no, and sometimes we just don't know. And I'll try and give you an example of each of these. But I think as we look at these, especially during the sunset process, we really need to look at more than just the big infrastructure changes, because if you just take the same systems and put them in different boxes, it's not reform and it's not going to improve anything. And we need to dig down as we go through the sunset process and really get to the ground level and really look at how the new system or the new structure is going to impact how we deliver services on the ground in communities and in your districts. So an example of some things we're doing right. I think the last legislative session there was an influx of or an infusion of additional dollars, and that did help in a lot of ways. We don't have the data yet to really tell us the outcomes of a lot of it, but there were things that we know were needed. We know that people with serious mental illness, if they don't have housing, if they don't have a place to sleep at night or take a shower, then they're not going to be able to work on their recovery, and they're likely not going to be able to manage their medications and that kind of thing. So the money that was appropriated to housing served over 1,000 people and provided housing services for more than 1,000 people with serious mental illness. We know that that's a good thing. We have things like the YES waiver, the Youth Empowerment Services waiver. It's the only Medicaid waiver we have on the mental health side, even though we have 6 or 7 of them on the disability side. And it only serves children, and it isn't statewide yet, although the state is working to get us there. There was a rider last session that directed the state to work on a plan to expand it statewide. But this waiver provides intensive community services to help prevent families from having to relinquish their child to Child Protective Services or to the juvenile justice system because they can't get the comprehensive and intensive mental health services they need. And these are kids and families who are really in crisis and need that level of help. So we need to, as we move forward, make sure that we keep moving forward on expanding the YES waiver. Right now, I think it's available in 10 counties, and those 10 counties represent about 60% of the population, but that still leaves, 244 counties without the program. So we need to make sure that we continue that. Some examples of some things that aren't working well and we should really look at and do differently through the sunset process. One is how we address the mental health needs of people with intellectual and developmental disabilities. For many years, for decades, for as long as I can remember, we don't talk about the mental health and wellness of people with intellectual disabilities. We talk about managing their behavior. We talk about making them compliant. We talk about what medications they need to calm them down, but we don't look at what are they suffering from: depression, anxiety, schizophrenia, bipolar disorder. And these are people who experience trauma and mental illness at twice the rate of the general public. So as we go forward and we merge some of these agencies, right now we've got disability over here and mental health over here, and never the two shall meet. And we really need to think of that level of service provision as we try and create this new infrastructure. Another thing that's not working in our state is that we continue the practice of parents at times having to relinquish their child to the state just to get the mental health services that they need. In my mind, that's one of the worst things our state does. And we've been working on it for a long time. We've made a little progress, but not a whole lot. But it's a very inequitable system. If I have a child with a developmental disability, an intellectual disability, I have an entitlement to place that child in a nursing home or an intermediate care facility or a state-supported living center. The state pats me on the back, sends me home to get some rest. I don't lose parental rights, and I get to continue making all the decisions about my child. If I'm that same parent and I have a child with serious emotional disturbance, a child who is a danger to himself, maybe a danger to his parents, maybe a danger to siblings, and I don't have the resources, or I've exhausted resources and can't get the help that the child needs, I don't have those same rights that the kids with IDD have. Oftentimes, the only option is for the child or the parent to relinquish the child to the state. They lose their rights as a parent. They have no more decision-making over what happens with their child. And on top of that, their names go on the Central Abuse and Neglect Registry, even if there was no abuse or neglect, and they were just doing it to get mental health services. So that's simply wrong, and we need to fix it. And it makes sense. I mean, if parents have to relinquish their child to the state's then paying for the mental health care that the child needed, but we're also paying for conservatorship, and that can go on for a long time. So it's like we're doubling the cost of the care for the child. So that's something we need to fix. Some things that we're on the right track, but we're falling short on. Leon mentioned peer support services. This is an awesome opportunity for Texas. We have a system in Texas to certify mental health peer specialists, to certify substance use recovery coaches. We have over 500 mental health specialists and over 350 certified recovery coaches. These folks have done an incredible job. They're employed at all 39 local mental health authorities and a number of the state hospitals. As Leon said, they have such an impact that doctors, nurses, even social workers sometimes can't have because they have the lived experience. The problem is that right now under our current system is they can only be reimbursed for those services provided by a peer support specialist when they're providing rehabilitation services at a local mental health authority. So that means that hospital ERs, integrated healthcare settings, community clinics, criminal justice, juvenile justice settings cannot be reimbursed for those services. So we really need to look at making peer support services a Medicaid reimbursable service. And we can do that in a very structured way where we direct the commission to identify exactly what peer support services are and who can provide them and what the requirements are for certification and what the requirements are for supervision. And that it's such an economical and effective way to really increase the support that the workforce, the mental health workforce, which we know we have a significant shortage. Consumer-directed services or self-direction in services is another area we've fallen really behind on the mental health side. Many of you may have seen Kate's editorial a couple weeks ago where she talked about self-direction.
If you didn't, it's in your seat.
Please read it. We've had self-direction and consumer direction on the disability side for over a decade. It's in all their programs. It's in managed care. On the mental health side, where it really makes more sense, it's lagged with one little pilot up in the North Star area. So we really need to move forward on that. And finally, I mentioned that sometimes it's hard to tell where we are with how we're doing, and it's primarily because of the lack of data. Now, it may be because we're too soon into the program to really have quality, comprehensive data to be able to evaluate, or it may be that we're not collecting the right stuff. Department of State Health Services releases figures every quarter. They call the data book, and it's got gobs and numbers and figures and dollars and that kind of thing. But we haven't been measuring recovery outcomes. Are people getting better? Are they getting jobs? Do they have housing? Are they engaging in their community? Are they taking responsibility and managing their own recovery? And we have ways to measure those things, and those are the things that will really tell us if how we're investing our money is working or not. So, 1 minute. So we really need to take a look and step back. And again, the sunset process offers a great opportunity to do that, to require different data collection and require different measurements and really look at whether we're changing the lives of individuals instead of just counting how many people served and how many services they got and how many dollars we've spent. So that's a very quick snapshot. The Hogg Foundation cannot lobby since we're part of the University of Texas, but we have spent thousands of hours working with legislators and staff, providing information, helping analyze bills, that kind of thing. So please call on us. We are there to help, and we hope you have a good session and really have the opportunity to make some significant improvements in our mental health services. Thank you.
Is this one on? Mic's on? Okay, good. Well, hi, I'm Andy, and I just, first of all, need to apologize that I am not Tom Luce.
We like you, Andrew.
Tom was supposed to be here today. Tom wanted to be here today. Had some unexpected health things come up that are minor, but he did need to be home recovering from that today. So he wanted me to send his greetings. Wanted me to, I think he did want me to apologize to. Wanted me to also thank Kate and the folks at TPPF for putting this on the agenda, because I think it's really actually, to me, this is very exciting that y'all are doing this, and to have, alongside all the other really important, you have a limited amount of time to focus in these 3 days, and we really appreciate you doing this. And I think it's a testament to the work that folks have been doing, advocating, a lot of the work y'all have been doing over the last couple decades, getting folks aware of what these issues are and needs. Tom has a long history in education reform, and he often will draw analogies there. And I think one that is pertinent to today is what he'll talk about. They spent about 2 years in public education reform convincing people there was a problem, and then they spent the rest of the time convincing people there was something you could do about the problem. And I think we're at a similar point in time in some ways in mental health, that I think we've got people's attention recognizing a lot of the needs that Leon talked about, the needs that are in the paper every now and then, including needs in Manifest in El Paso yesterday, when it's rare, but when people do erupt into violence. And we don't know exactly what happened there, but we can wonder, and it certainly reminds us of other situations where folks have committed violence. Those sorts of circumstances, I think, underscore the need, but a lot of times we don't know what to do. So I think the topic is really pertinent. I think the comic that you had also is really pertinent, too, because the metaphor of unintended consequences, we all have good ideas. I don't think anybody gets into this business, whether the business is policy making or the business is mental health service delivery, because we want to hurt people. We get in because we want to help people. We want to make things better. And a lot of times it's the unintended consequences of those ideas, and that's what I'm going to try to talk a little bit about today, and to try to give a framework that we've come up with at the Mental Health Policy Institute, the Meadows Mental Health Policy Institute, that's helping guide us as we, in many ways similar to Colleen, we're not going to be lobbying, but as we respond to requests for information, and we're certainly willing to do that and happy to lend any thoughts or expertise we might have as people have questions. The other thing I really liked about your metaphor, Kate, and I liked, Colleen, how you sort of talked about lifelines, and we need to not fixate too much on crises, and instead need to look at why do people end up in situations where they need lifelines. Seymour Saracen was one of the early folks in community mental health who talked a lot about prevention, and he talked about the metaphor of we're constantly pulling people out of the river before they go over the waterfall. What do we do about not throwing people into the river, not getting people into situations? And I think that's a very pertinent metaphor, because we spent a lot of energy in the state building best practice crisis services over the last decade, and we have them. But increasingly, we have a system that rotates people through crisis, rotates people through jail, but doesn't keep them in care very well. So I'm going to talk about a framework where we can try to get there. And to maybe help visualize a little bit about where we want to go, because I think Colleen's point about outcomes and Leon's point about outcomes being so critical are right on. There's a lot of data out there. What do you focus on? One thing I'd like you to think about in terms of my presentation is the data point that 50% of mental illnesses manifest themselves by the age of 14. So that means that children childhood is when half of mental illnesses manifest, and then many more of the rest, probably most of the rest, by the time we're 21, because that's a huge developmental time during which bipolar disorder, schizophrenia, and other disorders kick in. So we're really talking about very young people. And, Leon talked about 1 in 4. We have some data we're going to be releasing later this month from public polling data where it's actually 8 in 10 Texans have a close family member or person close to them that is currently being affected by mental health or substance abuse. And to put that in context, that is similar to the rate, and we asked the same people this question. These are Texas voters, by the way. We thought you might be more interested in Texas voters, just to be clear. 80% of them. It's the same rate that has a family member or close friend with cancer. So that's the level we're talking about. And just think about what the difference would be if you went into, I go to a church, that's my faith-based place. If I had a child with depression, well, actually, let me first of all, if I had a child with cancer, I think I'd probably tell people at church. It might be hard for me to tell them, but I think I would tell them. And you could bet that if I did tell them and they knew that my kid was going in for treatment, they'd be making me casseroles, they'd be inviting me over, they'd be doing everything they could. If my kid was depressed, I wouldn't tell them, because I wouldn't want them singling my kid out. I wouldn't want them, and I certainly wouldn't think any of them were going to make me a casserole. I think at most they were going to be awkwardly silent. So how do we move beyond that? How do we move into where we can be helping? And I think some of the examples that Leon And Colleen talked about our awesome strategies, actually all of them that they talked about. But how do we have a framework to think about that? And I'm going to give you sort of a 5-point framework that we're going to use to think about this. First of all, the first point of the framework is that Texans deserve care that works. And this is, I think, the premise of this sort of what are the right lifelines. They deserve care that works. In order to work, the care has to be efficient, it has to be effective, and it has to be the right care. One of my colleagues, who's a psychologist, is also a firefighter part-time. I don't know how he put those two things together. But he points out that, CPR is an evidence-based practice. But when he's doing emergency response, if he just ran in and started doing CPR on everybody that they do emergency response to, they would break a lot of ribs, hurt a lot of people, and have a lot of people die, because not everybody needs CPR. A lot of people do, but not everybody. We are famous in Texas for restricting our providers, like Leon, to saying, here's the 3 things you can do. Here are the 3 evidence-based practices, and you're allowed to do these. We'll remunerate you if you do these. We'll only remunerate you, by the way, if you do exactly 2 hours of these. If you do anything less than 2 hours, we won't. If you do anything more than 2 hours, you must not be very efficient, because we know everybody in Texas needs CPR for 2 hours. I mean, it's ridiculous. But yet, and it's not the fault of any one person. This is a great idea. It actually comes out of the same sentiment that we have for today's presentation, that we want to make sure we throw the right lifeline. There are hundreds of right lifelines. So how do we move beyond this idea that you can only have 1 or 2 and really build an accountability system where we're measuring the effects of treatment, we're measuring the effects of what Leon and his folks do, so that we can actually trust them to exercise their clinical judgment to do more than just 2 or 3 evidence-based practices? Well, one thing we have to do in order to get there is we have to make sure that state purchasing is accountable to Texas taxpayers, which it currently is not. Notice I said Texas taxpayers, because we pay taxes at the state. By the way, I'm a Texas taxpayer now, so I understand. I've been that way for 5 months, not as long as some people, but and we pay both state and local taxes. So it's not just the taxes that go into the state budget. So when y'all are thinking about how to spend the state taxpayers' money, you need to be thinking about local taxpayers who have to run jails and emergency rooms and all that. And there is not one person you can go to in state government to say, how much do we spend on mental health, let alone outcomes. They don't know how many people that spend it. And that's because it's nobody's job. I mean, if you were to think about where in state government mental health is, probably most people don't know. If you did know, you might think Dr. Lakey, even though he's still there for a little bit more. You might, if you really know a lot, you might know that it's Lauren Lacefield Lewis who runs the Mental Health and Substance Abuse Division. But she only has about $1.3 billion. There's well over $1 billion more being spent through the Medicaid program and being spent through the district projects that she has no responsibility for, and therefore very little knowledge about, because she doesn't have any time to worry about that stuff. So I think that's one benefit of the Sunset Review, is it is looking for a point of accountability. There's one behavioral health division in there, and I think you all should be trying to have legislation that makes sure that we have one person who knows how much is spent in the state. Because how are we possibly going to have accountability if we don't even know how much we spend? Then you could ask, how many people are we serving? Well, we know that they serve about 150,000 people through DSHS, but most people don't know that we serve about 180,000 people with big 3 diagnoses. Those are the severe diagnoses through the Medicaid system. And they only overlap by about 70 or 80,000 people. So there's a whole 100,000 other people out there not served by LMHAs that are served somewhere through the MCOs, through individual practitioners. We don't really know. But we know that they're out there and they're receiving services. And we're doing some research that will be released later this month through Dr. Rowan's group at UT Houston, which will hopefully give us a little bit more of an idea there. And we know, thanks to Dr. Stacy Manser and her team, Dr. Molly Lopez at UT, that you have about upwards of 185,000 people a year. There may be some duplication there being served through the district projects. Now, I don't expect you to remember all these numbers, but I do want you to remember that there's 3 big parts of state government with lots of people being served, lots of money being spent, and very little, actually almost no, coordination happening at the state level. There's tons of coordination that happens at Leon's level and happens in local systems, and we'll talk about that in a sec. Keep in mind, too, that there's about $2 billion by our current estimates being spent on emergency department care and jails at the local level, which, in case you can't do the math real quick in your head, is pretty much as being spent at the state level. So we have to get all of that coordinated, and I think that's a really important opportunity we have under Sunset. It's not something that just passing the bill is going to do. It's going to take the Legislative Oversight Committee over the next 8 years with the active advocacy and interest and data from folks like y'all and folks like the folks up here, making sure that attention is spent to this and we do a better job. The third principle we want people to keep in mind is that health care is local. Nobody delivers health care at the Capitol. Well, probably. Occasionally some people have heart attacks and have to be responded to. But health care happens through local providers like Leon. There are local providers here in Austin. There are people here who do care too. But that's for people who live here. And so we need to keep that in mind. So like, think about this, in the highway funds. Would we ever want to spend our highway funds here in the great state of Texas saying, look, you know, we estimate that when we look across the state, we need about 1 million more miles of freeway. And we're going to divide up those 1 million miles of freeway, and we're going to send the state out to pave so many miles of freeway in every major area of the state. And we're going to, whether you need a freeway or a bridge or sidewalks or public transportation, we've got freeways, and that's what we're going to do. That's what we do with state hospitals. I mean, there's a great report that came out that said we need 500 more beds at state hospitals. So what are we going to do? There's an LAR request out there to have 50 more beds next year and 100 beds total the following year. Really? I mean, is that what we should be doing? We should just go build 100 more beds? I'm not saying we don't have a need there, but wouldn't it make a whole lot more sense to go to the local mental health authorities and to say, look, we think you need this much more capacity. Do you want to build it on hospital beds, or do you want to build it on freeways, or do you want to build it on light rail, or do you want to build it on sidewalks or bridges or peer support? I mean, there's a whole lot of things that can keep people out of hospitals and help them move on. And, you know, if we wanted to put everybody in a hospital, that's the thing I hear people say, it's like, we need more hospital beds. There are 1 million people with serious mental illness in Texas. At a cost of $200,000 a year, it would cost $200 billion a year to put everybody with mental illness in a hospital. Now, I know nobody wants to do that. But people do talk about spending $100 million more a year on more hospital beds. And I just think before we do that, we need to have a community conversation and embed that more at the local level. The fourth principle is that we need to purchase meaningful outcomes. And that really, I think, aligns with what Colleen and what Leon are saying. And let me give you an example of how not to do that. Leon, I'm going to pick on him, runs one of the best homeless services in the country. And he talks about that, Haven for Hope, and then the Restoration Center. The metric, because we're purchasing outcomes, that was a big accomplishment of the last legislative session, and it was a good move. But the way it got implemented on homelessness was we decided we would measure homelessness the same way in every part of Texas. And not only that, we would set the same benchmark because we know that homelessness is evenly distributed across every county of Texas. There are exactly the same number of homeless people in Hudspeth County as there are here in Austin. And not only that, we know that the best way to measure you for that is to look at one single funding stream, who's paid for by DSHS, and to say you need to reduce the number of people that are on that funding stream below a certain level. Well, what's the easiest way to achieve that outcome? Quit serving homeless people. That's the easiest way to achieve that outcome. I'm not saying anybody did that. Leon did not, and so therefore he got penalized. Several hundred thousand dollars. He was penalized in the exact same year that we rolled out a $10 million statewide program modeled on his program called the Healthy Communities Program to build state-of-the-art homeless programs.
Yeah, he's right. If I was a good little bureaucrat, I'd stop serving the homeless. We'd stick them back in jail and back on the streets.
Yeah. So this is how good ideas can sort of take us off in the wrong direction. We think there's some ways to address this, but these are the four of the principles. The fifth one I'm just going to tell you because I'm out of time, too. We all did that, by the way. We all ran out of time. Which is why you should call us to talk more, is addressing our workforce emergency. We can't do any of this unless we have a workforce that includes peer specialists, it includes more physicians. We have fewer residency slots than the national average and way fewer than the states we compete with for jobs. And so we need to do an emergency investment in our workforce, both long-term solutions as well as short-term things like some of our onerous lack of reciprocity, our licensing standards that make it hard for folks to relocate here. There's a lot of things we could do, and I think those 5 principles will get us a lot closer to having the right lifelines.
Good job.
All right, well, I think we're going to go ahead and open it up to questioning from our audience. We have a lot to build on here. We've had a lot of good comments, a lot of good information about funding and outcomes, and so any questions from our audience?
My name is Bob Schoolfield. I wanted to ask Mr. Evans, you mentioned using some of the recovering
Clients.
Mm-hmm.
Patients.
Right, to attract the homeless people into wherever you take care of them. First thing I thought of was Alcoholics Anonymous. Mm-hmm. You know, where the main leaders of this thing understand alcoholism because they've been an alcoholic.
Mm-hmm.
What if, I mean, can you take that model?
You cannot, and we do, and let me tell you about it.
Okay.
Okay, so remember we asked Mr. Greehey to go work with the representative in the Senate and get us some money. We added a sobering and detox unit. So here's what used to happen in San Antonio. San Antonio is a tourist town, right? We got tons of homeless people downtown. who are aggressively panhandling, getting arrested all the time for passed out in the street, aggressively panhandling, urinating or defecating in public, petty crimes. So they get arrested, and this is the United States. You get arrested, you have to go through the magistration process, right? The city of San Antonio spent about $16 million in magistration. I don't know what percent was with this group, but a big percent. So they throw you in the drunk tank. Well, first they give you a fine for whatever little nasty deed they picked you up for, which you never pay. They throw you in the drunk tank, and they let you go before you sober up because they don't want you going into convulsions and DTs and dying because they've already paid. They've already paid some of those $1 million lawsuits. So they let you go. The people go out and start self-medicating again, so they start panhandling and drinking. Some of them get arrested 3 or 4 times, and they have no insurance, and they're impaired, so they would never get any help. Their illness has been so painful for family and friends, they don't have anybody to advocate for them either. So now, remember, we've got all these cops trained in mental health. Now we've developed this sobering unit. So they bring them to us. They don't even take them to jail or magistration process unless they've committed a major crime. Everybody in that unit, mainly on recovery, it's a medically supervised unit, but it's not a medical model, so the cost is real low. We used to have beds. People are falling off hurting themselves, so we just have mattresses on the floor. But our staff are bathing those people. They're treating them like they're in the Hilton with dignity and respect. And they're saying, hey, I used to be sick like you. Don't you go to the other side of that wall and go to detox? And about 20% of them say yes. Well, detox is a necessary intervention, which we all know don't work too well, right? Just ask Lindsay Lohan and probably a lot of your friends who have been through detox. What's important is how you maintain your sobriety after your detox. So on that homeless campus, remember it's alcohol and drug free, we have 2 dorms that we operate. They're called in-house recovery. So it's a 90-day program. You're in there long enough to learn what your disease has done to you, your family, your children. It also is long enough for your brain chemistry to start kicking back in. Just because you're detox doesn't mean your brain's working right. And we use seeking safety, best practices on alcohol and drug treatment. Then we're hooking you up with AA and NA. And I'm going to tell you something you're not going to believe. About 60 to 70% of those people who go through that program a year later are still clean and sober. Most are working and living independently. That's probably better than Betty Ford, and the cost is like that. So there are models out there if we had the flexibility. When we first did the unit, Dishes had no standards for sobering. They made us license all the beds as detox. Well, if their rules said you had to have a waiting list, and that won't work. So we just defied the state. I took a bunch of those detox beds offline and made them sobering, and now the state takes credit for it because it's a model program. It works well. But we do a lot of things like that, and I've just talked about a few things. Children's services. We developed the first curriculum in the United States for school police. And school police usually are right out of academy. They're trying to use their command voice and their command presence. And a lot of times school police are kind of entry-level jobs because they're 9 or 10 month jobs and they don't pay, and you're not in front of guns all the time. So you got this young officer and you got some teacher calling saying, I want you to come and get this kid and I never want to see him again because he or she did X, Y, and Z. So you got a young officer charging forward, gets in this kid's face, who's emotionally disturbed or mentally ill, and full of hormones, and there's some kind of altercation. So the kid goes to juvenile detention, or he gets kicked out of school, and becomes estranged from school, becomes a truant problem, gets involved with gangs. I'm talking generalities. Now these cops are trained to recognize this kid has emotional disturbance. And there's lots of role playing. They step back, they use de-escalation techniques, and they call the family and they call us, and we get the kid help. And one of our 1115 district projects is we developed a children's crisis unit, just like we did for adults, where those 25,000 people go. It's just now open, and it's already working well. We're also going to do respite care. So she was talking about families who have mentally ill kids who just are pulling their hair out. They just can't take it anymore. There's no respite for those families. Nobody's teaching them or coaching them. So we do lots of super nanny training, too, with all our employees, We want to promote the right kind of behavior, ignore the wrong kind of behavior, and help these kids get to a place where they can manage their illness. So,
everyone is proud of the success demonstrated in there. Excellent.
thank you, Representative.
You mentioned early on that you had a generous benefactor that helped you achieve some of your goals. How is it replicated throughout the state without
Well, we actually made most of the progress before the homeless. So I left TDMHMR in 2000 and went to Bexar County. We started working on the training and the diversion programs and kind of knitted those programs together with hardly any money. And then maybe it's 2008 or 9 is when Mr. Greedy came along. And remember, we had these community collaborations going on for a long time. And we knew substance abuse was a big problem. We just never knew how to fund it. And that opportunity, working with Mr. Greedy to find a way to put the substance abuse part into it, worked out. I think last session the legislature actually funded some $5 million projects for if the local community would also come up a public-private partnership. So I think there's opportunity for at least 5 communities in Texas to do something similar that happened in Bexar County with a public-private partnership. And I'm actually able to prove to the Commissioners Court that what we do reduces jail population. So they don't mind investing a few million. You know, the city, the registration costs and all that, the fact that law enforcement officers used to wait 8 to 14 hours in emergency rooms waiting for medical clearance and psych evals. The Restoration Center, they do in 15 minutes. We also do what's called injured detainee. So even if you don't have a mental illness or a substance use problem and you've had a scuffle with somebody you arrested, you don't have to go to the emergency room anymore. You can bring them to us. We'll sew you up, give you a tetanus shot, and you can take the person on to jail or whatever. So because we have that capacity and we have this great partnership with law enforcement, so it's all about finding best value for the community, and because that, you know, the city sees the value. So, and the same thing with the hospital district. The number of people in emergency rooms and bedded in our hospitals are way down. So we get that money. The HIEs, the Health Information Exchange, we working there. We identified the high utilizers in emergency rooms with mental illness. These people that go, you know, maybe 3 or 4 times a month, that pack our emergency rooms, who really shouldn't be there. We've done a wraparound program. In fact, it's worked so well. We've done research with the medical school there that Health and Human Services asked us to do a webinar about it. But so we just kind of look at these as system problems that somehow we can find a way to knit the dollars together and blend those state, local, and federal dollars together. And if we can't, we're not going to give up on it. We're going to find a way to do it sooner or later.
Well, and I think just to pick up on Leon's point about the Healthy Communities grants, those are the 5 ones that came out of SB 58 that Senator Nelson developed last session, and were funded at $5 million, and then were matched $5 million in the community. Those went to the 5 biggest counties with 1 million people plus, and they were able to come up with the match there. And I think I think the first thing we need to do is recognize that this sort of state-local partnership has to be a design principle of how we pass funding out. That's, I think, the point I was trying to make with the state hospital dollars. Senator Nelson has released Senate Bill 55, which is out, the Texas Veterans Initiative project, which sort of takes that to the next level, and we're partnering with them on that. Just kind of disclaimer on that. We have an RFP out right now. The way we're doing that is we're partnering with HHSC. They had $1 million of unspent dollars in this fiscal year. We were able to go out and talk to a network of local foundations, and they sort of fall into 3 categories. One network said, look, we'll just put money into the initiative so that even if parts of the state that don't have a Bill Greehey living there, you can use the money there. There's very few foundations that have a statewide framework. Meadows Foundation is one. There's a couple other ones that have given some money for that. The biggest group are local foundations that have a pretty big scope and are able to give, but they have to do it within their region. So on this TVI initiative we're doing, we're going to categorize all of the proposals we get by region. And so what that'll do is during the selection process, there'll be an opportunity to basically showcase the successful proposals to those local foundations so they can see what in their region they're able to do. And most places in Texas have some level of that. Then the third thing we've done is we've allowed other resources to be categorized. So if you're in a rural area where you don't have a foundation partner, you're not asking perhaps for a $5 million program, you can use local in-kind resources, you can use other types of things to match. So it's a generous local match framework. And we think that this framework could also be used with the crisis redesign. I think there's other applications for this. And it's not going to be exactly the same partners. The same foundations that want to help veterans aren't necessarily going to be the ones that want to fund a reduction in number of people in their local jail. That's not always a big sexy thing for foundations to put on their cover. But it is pretty attractive to local governments if they have the kind of data that Leon's talking about. And like we said, I think just in the I think 8 of the biggest counties that we've been able to look at so far, there's about $160 million a year spent on the care of people with serious mental illness in their jails. So the match is out there. It's just that we have to, at the state level, conceptualize that this is how we should be doing things, as opposed to saying, look, we'll give you this money if you do 1 of 3 evidence-based practices.
So, Madam Chair, I'd like to give another example about, we at the state level, we want to promote local investment in a partnership with the state where, everybody's driving these right behaviors. I can tell you that doesn't happen. For instance, the local dollars I just told you about allowed us to overserve. The second year of the biennium, we served over 2,000 adults more than the state contract. And by the way, the state contract is not associated with the funding. And like 600 more kids. So the state turned around and said, we're going to add that to your target. If you're a businesswoman, I work for you, and I generated a lot more than you expected, you wouldn't be punishing me. Nobody put a lash to me to serve 2,000 more people. We served 2,000 more people because we thought it was unethical to put people in jail with illnesses, so we stretched, we begged, we did everything but we actually got punished by the state by doing that, and I can give you several examples of that.
Well, but Leon, there's a part that's because the state agency that's overseeing you there is not rewarded when you save money locally, and they are not rewarded when you do a better job with your Medicaid clients, and they are not rewarded when you do a better job with your district clients.
But that's a point. I think.
Yeah, I think it's the organizational.
Yeah, we have a chance here to kind of change the behavior at the state level, and start rewarding better outcomes in these investments that benefit everybody.
Which I need to say, I think as you all think about legislation and trying to hold agencies accountable and really hammer them, that's what causes, to some degree, I mean, nobody thinks, by the way, their good idea is the one that has the unintended negative effects, right? You know that, right?
Right.
Including me. I mean, I don't know that either. All these good things I'm saying are sure going to have some unintended effects. But this idea that we need to hold agencies accountable, and by gosh, we gave them this money, and we're still tracking at DSHS money spent on new generation antipsychotics that were new generation when we first gave them that money in the late 1990s, but are no longer new. I had a lot of new things in 1998 that aren't new now, but we still track that money. We still hammer them on that, make them parse out where that money's spent. I mean, Leon, how much time do you spend trying to figure out where you spent the new antipsychotic money from 19 whatever versus your other? I mean, you spend time doing that kind of stuff.
Yeah.
So I think that when we hammer them on accountability, that's why we got to hammer people. Yeah, I'm all into accountability, but we got to do it in a way that accomplishes our goals.
I've heard Colleen talk about just the parents having, to give up their parental rights just to get treatment for their kids. Tell us a little bit about the ideas that you've got out there for the least restrictive environment for those parents to be able to keep their kids at home and still do the services they need. What are some of those ideas that you're plugging out?
Well, I mentioned that we have made progress. We haven't solved the problem, but we made progress. Last session, there was funding for 10 slots. So 10 children that were on the brink of relinquishment could get the mental health services, their families could get support, and prevent that relinquishment. Of course, 10 slots in a state the size of Texas doesn't last very long, and so they managed to extend that to 13 or 14, and they're all being used. There's a waiting list. So we need to look at the system differently. DFPS, Department of Family and Protective Services, would always say, those kids don't belong in our system, go talk to Department of State Health Services. And the reality was that these kids were ending up in their system. They may not belong there, but that's where they were ending up because that's where they could get the services. So I think the department has asked for an additional 20 slots this in their LAR, and so hopefully there'll be some additional. And of course, the average length of stay in the treatment is usually about 6 months. And so those roll over, and so it's more than 30 kids served, but it still may not be enough. One of the problems, too, we have to look at what we do to these parents when there isn't a slot available and when there aren't services available. And we put these parents' name on an abuse registry for doing one of the hardest things a parent could ever have to do. And they're doing it because they love their child, they don't know how to help their child, they can't get the resources to help their child. So we really need to stop that piece until we solve the other piece and how we're going to help them without making them relinquish their child. Now, as a result of the funding and the diversion slots, as they're called, for the first time, Dishes and DFPS are working together. And so if a kid comes and is on the brink of relinquishment, those two agencies are talking to each other, and they're trying to see if maybe the YES waiver, the Youth Empowerment Services waiver, can benefit the family so the child doesn't have to go into residential treatment, or if there isn't a slot for diversion services available, you know, the local mental health authority is working a little bit harder to see what that family needs. And that's the kind of thing that we could build in a new system that we haven't done. It took legislation, Senate Bill 44 last session, to make those two agencies talk to each other and work on this. So I think folks understand the problem. A lot of times when I talk about it, people say, oh no, we don't do that in Texas. But we do, and we have for a long time. And one of the things that was in Senate Bill 44 that we thought was really important is if a parent has to relinquish a child to the state to get those services, at least offer them joint conservatorship, so you're not breaking the family apart permanently. And that was, you know, what passed as Senate Bill 44 was definitely not what was proposed and what we hoped to, you know, see happen. It was watered down quite a bit. But the joint conservatorship was a big piece, but we don't see it being used very much. And so, you know, we've made little steps, but we're still seeing a lot of opposition to changes in that. And we need to keep the pressure on both agencies to make sure we stop doing this to kids and we stop doing this to families.
You know, and just to use the same example, I mean, again, we like to wait till people need a lifeline, because then we're, oh, well, they must really need it then. So we wait until people need residential care. And that's good, but again, we do it at the state level where we fund 10 beds at the state level. We put it in the state, and we don't even look at the other evidence-based practices like multidimensional treatment foster care, functional family therapy, 5 or 10 other ones that have proven ability to help keep kids in the community as an alternative to residential care. We don't even talk about funding that. And whereas we could, if we said to Leon, hey, you know, Leon, you had 5 people on the wait list for this. You had 5 people that had to do this in your area. Give us a plan. We'll give you $3 million to come up with a plan for how you could do that, and I bet you could figure out how to keep those 5 people out. You got to use an evidence-based practice, show there's some national source on it, show us the research for that, but give us that plan on how to do that, as opposed to try to come up with these plans in the legislative session, write it into the bill. You got to do 10 beds, and that's going to solve the problem. I mean, I think we need to move to more of a systemic thing. And if we have the outcomes in place where we know we can make sure Leon doesn't do bad things, because we do have to watch him, we can then hopefully trust him more and untie his hands and let him do some of these evidence-based practices that work, which actually have better evidence than residential treatment, just to be clear.
So I'll give you a good example that we're talking about kids, right? So remember I told you we had 2 community collaboratives. The other one's around children. So we work with the children's hospitals, and one of the things we were finding out is that all the child serving agencies were dealing with this Pareto effect, this small group of kids who were really troubled, who were in several different systems. So they were getting trouble in school, they may be put in special ed, they had a counselor, a lot of them also had a safety plan, so they're involved with child protective services or juvenile probation. Chances are if they have emotional disturbance or mental illness, we're seeing them. So these parents are pulling their hair out. They don't know whether to work with the public schools or obey the probation officer or CPS or work with our mental health. And our group said, this is just not right. So we passed the bill 3 sessions ago now, that it was made permanent for 10 years this last session, called Bear Cares. And this is no new money, by the way. It requires the education system, child protective services, juvenile probation, and the mental health system on these high kids to come together, have one mental health plan, one safety plan, and one behavioral plan, and one case coordinator. And we also hire parents, like we do peers, to help the other parents learn how to navigate the system and answer questions and that kind of things, because they're family support people. So there are smart things you can do. Now, one time I was the director of community services, Texas Department of Mental Health and Retardation. So I knew that if we passed a bill and made the local entities do that, they wouldn't do it. So the bill actually required the state entities to report back to the legislature. And so that got the commissioners involved because they had to report. So, yeah, we got the kind of local support that actually meant now everybody's bought into it because they can see that what a benefit this has been to the children and their families.
I think we have time for about one more question. depending on the length of the answers.
I've got a real important one. So we
All right.
No, you'll appreciate this, Madam Chair. So this last session, we took all the rehab services away from the community behavioral health, the mental health authorities, and we turned it over to the MCOs, right? Now I want to talk about disconnect in state government. So you got dishes over here that decided we'll do a new assessment. It's called ANZA, and I want to make sure I get it right. Adult Needs and Strength Assessment. So when we do this adult assessment, we talk about positive things about these people that have severe mental illness. We don't talk about their multiple admissions to state hospitals and how dysfunctional they are and they don't have supports. But to get rehab services that these people direly need, the MCO doctors are looking at our assessments and saying, there's nothing wrong with this person. I'm not going to authorize that service. So we're not, we have this strength-based assessment that's really not giving the right picture to the funder who should be funding, these critical wraparound services, these rehab services to the people that need it the most. That's stupid.
Okay. And that's actually a state-of-the-art, that is a best practice measurement thing, but the reality is it's only a best practice if you train those physicians in how to use it and how to interpret it, and then you hold them accountable and you hold the managed care companies accountable, because absolutely, if you've got a financial incentive to do less care, you're going to find ways to do that.
Well, that's our experience.
Yeah, no, absolutely.
Well, and I just want to mention from the parent perspective, not just with this, but with a lot of things, you bring your child up through the school system and you're trying to convince the schools how much your child can do and is capable of, and you don't want them to really limit their expectations. So, you really push the child's abilities and strengths. Well, when they turn 18, if you're pushing abilities and strengths, then you can't get services, because services are based on, what you can't do and how badly you can't do it. So we really need to look at how we measure that, because there's a lot, as a parent, I might sit up here and tell you all the great things my daughter can do, but at the same time, there's a lot of things. She can't live by herself. She can't, do a lot of things without support. So we need to look at the system differently and not just say, well, you only get this service if you're eligible for institutionalization. That's ridiculous, because what happens then is we end up institutionalizing those with the less severe disabilities, because we're providing the community services for those with the more significant disabilities. So all of this plays into how we frame our service delivery. And like Andy said, a lot of it depends on what's going on at the local level. But at the same time, we need to make sure that everyone across the state, that we just don't have pockets like in San Antonio where people are getting services, that we make sure that real quality services are available across the state.
All right, one more question. Yes.
I want to preface this by saying this, please don't laugh. I'm a state rep from the state of Illinois. Is there a place where I can see some of the policies and some of the bills that you guys have introduced? Because Illinois is just waking up to this problem. Prior to becoming a state rep, I was a police officer for 8 years. So I dealt with this head on, especially I was a trained
Sure.
negotiator.
I'll give you a card and I'll send you a bunch of information. In fact, I spoke at Loyola Law School about 2 months ago in Chicago.
We also have, after legislative sessions, do a legislative summary on mental health issues, and if you give me your information, I can send you one for the last several sessions.
And we also have some briefing papers on the current one, so I'll give you our cards. You can get inundated with information. You're a good model for everybody else who wants to be inundated with information. Yeah.
Unfortunately, we can't pay for a lot of the services.
Yeah.
We have a 5 trillion backlog of unpaid bills.
Need to start fracking more.
All right, well,
Tony Breckwickle is a good friend of mine. Yeah.
All right. Well, mental health is going to be such an important policy issue this legislative session. We're so glad we could be part of the discussion on it. If you have questions, I'm sure our panelists would be happy to stay and answer. Please feel free to contact me at TPPF if you have any questions regarding mental health and our stances on it. I'd like to thank our panelists, Leon Evans, Colleen Horton, and Dr. Andy Keller for taking the time to come and share their experience, their expertise. We really appreciate it, and I hope you all enjoy the rest of policy orientation.